Hello, everybody. My name is Kate Wakelin and I am the Net Patient Support Nurse with Neuroendocrine Cancer Australia. Welcome to our weekly Facebook Friday broadcast, but actually you'll have noticed it's not Friday. We're actually doing this on Thursday because we have a very special guest with us, Associate Professor Patrick Charles, and I'll introduce Patrick a bit more in a moment, but we're grateful to everyone for joining us, and especially grateful to Patrick for sharing and joining with us today. So before I go any further, I just would like to pay my acknowledgement to the traditional owners of the land that I'm broadcasting to you from, which is the land of the Wurundjeri people and of the Kulin Nation, and would just like to pay my respects to elders past, present and emerging. One of the things, and I say this every week, but one of the things I adore about living where I live is that I'm very close to the Yarra River, and I love to go running along the Yarra, which in the Woiwurrung language is called the Birrarung. So when I go running, it helps me to feel grateful for where I live, and knowing that you are joining me from all corners of the country, that there are traditional owners of the land that you are joining me from too. So I'm just wanting to extend that acknowledgement to where you are joining me from too. So you'll notice we have a guest with us, Associate Professor Patrick Charles. I should just let you know we're a smidgy bit late starting the broadcast today because we had some Wi-Fi issues, and I feel terrible that Patrick's actually sitting on the floor. So you can see I think it might be waiting room chairs behind you. So if we see him starting to wriggle and look uncomfortable, that helps explain why. I'm very grateful that we've got an associate professor sitting on the floor because it was the only place that we could find the Wi-Fi appropriate for the broadcast. So thank you so much for hopping out of your comfort zone, Patrick, and for joining us today.
Thanks for having me, Kate.
Patrick, you're an associate professor and you're in Scrubs, so we're assuming you're a doctor, but can you tell us your role?
I'm a physician in both infectious diseases and general medicine at Austin Hospital. We're also doing some work at Warrnambool Private Hospital. So I do mostly clinical work with some research along the way, and also quite a bit of teaching. Well,
I imagine you've had a pretty busy year.
It has been an interesting year. We kind of start our careers in infectious diseases getting really excited about the prospect of something like a pandemic and our role in that. The reality is a lot more sobering and challenging than probably we would have guessed as junior doctors, and it's definitely been a tough year, and probably I think we'll all be glad to go back into the shadows once this is all over.
I know it's really put people like you in the limelight in a way that perhaps you might not have anticipated.
No, definitely not.
Yeah. So I think you'd have to be living under a rock to not know that COVID's had a significant impact for really all corners of the community. And I don't want to spend too long on the basics because I feel like this has been covered quite a lot, but just for the purposes of feeling like we're giving complete information, I'm wondering and we've had quite a few questions that have come in ahead of time from our patient community, which is fantastic. And there'll be patients, I can see quite a lot of them are watching already. So we'll have patients asking questions as we go. But I wondered if you would mind just giving us a very quick overview of what we know about the impact of COVID on people with cancer. And then if there's anything particular about neuroendocrine cancers or neuroendocrine tumours that are worthy of note.
So certainly there's been a lot of information suggesting that people with cancer, and that really has kind of included essentially any history of cancer, whether it's currently active, being treated, particularly with drugs that might be weakening your immune system now, versus any cancer. And it's kind of been all lumped in the same group effectively. And the studies have shown that the people that in that group do have a worse outcome. And so obviously there's other groups as well, like people who are older and people with other conditions that weaken the immune system or the lungs or heart. And so probably the problem I think that we don't fully know yet is the difference between somebody who's currently being treated with aggressive chemotherapy now versus someone who maybe had cancer 20 years ago. And with that fact that they've all been lumped in the same group, and yes, that group has a higher risk, I suspect that it's going to be the people who are sicker now who are being treated with those more immune suppressing drugs, chemotherapy drugs now, versus someone who's had cancer a long time ago and is in very good health now. So I think we still haven't teased that out, that difference. But I suspect that it'll be those people who are well and truly past their cancer treatment and not on any active treatment now, just being kind of observed, essentially. That I think the risk for them will be much more similar to the rest of the community who don't have health problems.
And is it that people with cancer are likely to get more sick if they catch COVID, or are they also more vulnerable to catching it in the first place? Or is that a question we don't have an answer for?
Yeah, it's probably more risk of getting sick once you catch it. That doesn't appear to be a huge extra risk for catching it in the first place. But I think really the problem is if you get it, you're more likely to be in that group who gets sicker, either needing hospitalisation or potentially need to go to intensive care.
Okay. And in terms of neuroendocrine tumours, is there anything to add alongside the general bucket of people with cancer?
I don't think that's really been teased out either. So it's really just been sort of one big group of cancer. And so obviously that's a huge group, and there's obviously such a huge array of different types of cancers and different treatments for those cancers. And so I don't think there's been a great deal of detail in specifically targeting certain types of cancer. So
it might be something I guess we'll learn. So I think the topic of the day for everybody is around vaccines, and I've been watching this develop incredibly quickly compared to most vaccines that we hear about in the community for other illnesses. One of the things that people worry about, or I know are worried about, is the speed of the development of those vaccines. And I think people are feeling worried that perhaps because that development has happened really quickly, that maybe we've not tested them as rigorously, or maybe we don't know as much about how safe they are, especially for people who might be more vulnerable. So I wondered if you could give us some comments about that process, what it's been like from your observation and what we know about the safety of these vaccinations.
Sure. So certainly it's an incredible pace of development. It's unheard of, really. The record for a vaccine being developed in the past was about 4 years for mumps vaccine. So to do it within 1 year is really incredible. It's amazing what happens when people put a huge amount of energy and an enormous amount of money into something like this. So in terms of the safety, the studies for these vaccines have been absolutely enormous. They're much bigger than other vaccine safety studies, really. And we've now got the extra information coming from around the world, where over 200 million doses of the various vaccines have been given worldwide. And really what our expectation was a few months ago, when before there was any vaccines, was, oh gosh, will these work at all? How effective will they be? How safe will they be? We just don't know. Now we've been able to get so much information so quickly that it actually looks like they're better than we could have hoped, both in terms of they're more effective at preventing severe disease and probably also preventing any infection, which we didn't think would be possible at all. But it looks like it's giving some effect for that. And then on top of that, the safety data is looking really good. And I think what's worth keeping in mind is when we've seen problems with vaccines in the past, and obviously we have seen problems with some vaccines before, particularly when we look at the concerns about long-term issues, they've always shown up early on. So within definitely 6 weeks, and generally a lot less than that, of the time of giving the vaccine. So the fact that we've gotten to now 200 plus million doses being given, and there's really no big signal of concerns about safety issues there, that it's really looking very reassuring. So I think it's certainly, the news is looking really positive. Obviously, people say, oh, but we've never used, like, particularly these mRNA vaccine, like the ones from Pfizer and Moderna. We've never used anything like that before. And that is true. But for any other vaccine, whenever there's been a long-term issue, it's always showed up early. And so we just haven't seen anything that makes us think that's likely at this stage. So I think the news is looking pretty good.
That's really, I guess, quite reassuring, Patrick. And I'm wondering how rigorous, and I'm skipping around my list of questions, and I have got a comprehensive list in front of me. So if you see me looking down, I'm just looking at my cheat notes. How sure can we be that that safety data is being reported accurately. And, you know, I know that there are laws here in Australia about how adverse events are reported, and I've worked a bit in clinical trials. So from a personal perspective, I am confident that that would happen here. But how confident that we can be, like you mentioned, the 200 million people stat, which is extraordinary. But how do we know that over in another country that those statistics are being reported accurately?
So there's all these different registries around the place looking at people who've been vaccinated and then studying the effects, and absolutely anything that occurs afterwards gets put in those registries. So if you have your vaccine and then walk out and get hit by a bus, then that gets put in the registry of like, no, this could be related to the vaccine. And then they compare, all right, well, what's the rate of people being hit by a bus after the vaccine versus people who haven't been vaccinated getting hit by a bus? And so whenever there's anything at all happening, then that is being carefully studied. And with these kinds of numbers, you do get pretty good results pretty quickly. There was some concern a few weeks back where people started raising about, oh, what's happening in Norway? There's been, I think it was like something like 47 deaths in people who'd had the vaccine in the few weeks afterwards. And then the Norwegians saying, what are you worried about? This is when we're going into the high level care nursing homes and where the people are very old and very frail. And of course, some of those people would have died anyway. And the figures for the ones who died after vaccine versus the ones who died not getting any vaccine was exactly the same. We don't think this is related to the vaccine. It's just the fact that you're studying a population who are very old and very frail. So there's things like that that are giving us really reassuring results based on these huge registries of most people getting these vaccines. So it's looking really good. And I think what I actually think is the second question that people aren't really asking is, okay, we're certainly looking very carefully at long-term issues related to any vaccine such as this one. But what's, I think, an even bigger question is, what are the long-term effects of not getting vaccinated and getting COVID? And so we've obviously seen, there's certainly people getting very sick and there's certainly people dying. And then on top of that, there's this group of people getting what's called long COVID or COVID long haulers. And where they've looked at that in Israel, they're looking at even in children getting COVID who generally don't get very sick at all, that about 10% have not recovered. And so they're looking at this kind of, it's almost a bit like a chronic fatigue type syndrome. So where some of these young children who got very mild illness from COVID just have not gotten better. And they have talked about maybe even 10% of children who got COVID are still really struggling to get back to their normal life, just in terms of aches and pains and severe fatigue and so forth. So we know there's those concerns with COVID. And then on top of that, we know there's a lot of viruses that do have an association with causing cancer. So obvious ones being human papillomavirus, but also things like Epstein-Barr virus causing some types of, say, lymphoma and other cancers. Hepatitis B and C lead to liver cancer. HIV is associated with a whole lot of cancers and so forth. And then, so we haven't obviously had time to study that with COVID. Could this be associated with cancer? It could. And also we know that it causes this really intense inflammation and particularly affecting the lining of your blood vessels, also called the endothelial or endothelium. So when you've got intense inflammation of blood vessels like that, then I think it's very likely that we're going to see a whole lot of extra heart attacks and strokes in the coming years. And when we see a bad flu season, that intense inflammation you get from the flu is always associated with the next 1 or 2 years, you get many more heart attacks and strokes, particularly in the elderly. So I think it's very likely we're going to see something like that happening with people who've had COVID, that their risk of having those kinds of conditions in the next few years is much, much higher. But we don't have that yet. And so I think, yes, we're certainly concerned about long-term side effects of vaccines, but with 200 million doses and no real signal of that yet, at the same time, we've had 100 million plus documented cases of COVID, and with 2.5 million deaths and probably 10 times that many long haulers, and then who knows what other long-term side effects from this. And when you get the virus infection, you get the virus all over your body. So it's going to affect so many different cells. Whereas when you get the vaccine, it's really just kind of affecting these muscles, where you inject into the muscle, what's called the antigen presenting cells in there, or otherwise called dendritic cells, which then go to the lymph nodes in your armpit. And that's why you get the sore arm and the sore armpit afterwards and so forth. So it doesn't kind of affect all your cells in the way having a virus does. So if there's going to be long-term problems, it's much more likely from the virus than from the vaccine. That's
really reassuring, and thank you for explaining that. And I think it's it's easy, I think, in Australia to forget the serious consequences of COVID, because we've been so fortunate in the way that we've been able to control the virus in our community that we haven't seen. You know, when a year ago, I remember reflecting and thinking, goodness me, who do I know is going to die from this? I was actually really frightened by it. And I know that, you know, my friends and associates in other countries are very much.
Sorry, I just have to move to get the sensor to make the lights turn back on.
You're really dark.
Sorry.
See, he really is sitting on the floor.
Yeah.
I wondered about, you were talking about the vaccine, Patrick, only affecting the cells in your arm. People are, I think, worried about the concept of the vaccine making changes to our DNA. Can you explain in lay terms how this works, so that, you know, how does that work?
So probably the biggest concern for that would be the new types of mRNA vaccines, so the ones from Pfizer and Moderna. So with those ones, it's probably worth looking into the slightly complex question of, well, what is mRNA, and M standing for messenger. And so if you had, say, like a virus made of DNA or RNA, then those can get into your DNA. And in fact, if you look carefully through the human genome, about 5 to 8% of all of our DNA is junk DNA from viruses. So this sort of thing happens all the time. So we already have lots of our DNA already filled with the virus DNA that things we've caught, or our ancestors have
changes to our DNA. Yeah. Is that what you're saying?
Okay. That's correct. Yeah. But if you then go on to particularly say the mRNA vaccines, so once you get to the M stage of mRNA, then that injected goes inside the cells, but it doesn't go anywhere near the nucleus, which is where your DNA is. It just goes into the part of the cell which produces the proteins. And so that mRNA gets in there and then will produce the protein, in this case, the spike protein of the coronavirus. And then that's what we want, is for that to happen at least in some of these what are called dendritic cells, or antigen presenting cells. And then they then show it to your white blood cells and teach them to recognize the spike protein. And so that then they can start producing immune response against that. And with the mRNA, it's incredibly fragile. And that's why it has to be stored at such a cold temperature. And you have to be really careful with the vaccines, even to the point of not shaking them too vigorously, because the mRNA breaks apart really quickly. And so that mRNA itself is very fragile. And so it breaks apart not long after it's been able to produce its protein. And on top of that, the dendritic cells that it's inside, they die within 2 weeks. And so you just get that kind of early exposure to the mRNA, which doesn't affect your own DNA at all. And then that is used to then produce an immune response against the spike protein. And so that you then are going to have that immune response for a long time, hopefully. How long? Not really sure. But it's not actually going to affect your DNA, and certainly not in the way actually catching the virus would. So when you catch a virus, most viruses do end up getting inside your DNA itself, and that's where they replicate. They kind of just put their own genetic material into your chromosomes and your DNA, and use your own normal replication of the chromosomes to replicate the virus as well. So it's actually a lot worse with the virus than it is with any vaccine.
That's so fascinating. And look, you know, I'm a nurse, but I haven't actually heard anyone explain this in this way before. And it actually reminds me a little bit about the way that immunotherapy works in cancer, that we're actually kind of awakening the cells to recognize the cancer cells as being a problem and being able to fight.
Yeah.
Yeah, no,
that's exactly. Yes.
Thank you. I think that's really, really helpful. I'm just looking at, there's a few questions come through, which I'll come to. But I did want to sort of specifically talk through some more of the questions that were submitted before our chat today. So one person asked what immune complications would potentially arise down the track if one receives the vaccine. I think we've possibly answered that partly, but is there anything more to say about that question?
Yeah, the major side effects we're seeing, certainly you get a sore arm, and then you might have a low-grade fever, aches and pains, feeling a bit tired and fluey in the day or so afterwards. sore arm might last a bit longer than that. And then some people also with the mRNA vaccines say that about a week afterwards, the spot where they got injected gets a little bit red and itchy. And the lymph nodes in the appropriate arm often get a bit swollen as well. But other things related to particularly immune function, we haven't seen anything so far. Obviously, we're still looking and we will still be checking and trying to study that. But it doesn't look like it's a major problem for that. And I think, again, that thing of the immune response to the vaccine is much, much lower than the immune response to the infection. And so when we see that huge inflammatory response to the infection, that's obviously a lot worse. And if we look at the example of influenza and influenza vaccines, which we know that the flu vaccine is not a particularly effective one, that question about after a bad flu season where that intense inflammation when you get the flu leads to much higher risk of heart attacks and strokes in the 1 or 2 years after, when you give people the flu vaccine, including the elderly who often don't respond all that well in terms of prevention of getting heart attacks and strokes in the subsequent years, is definitely lower than it is with the people who are unvaccinated. So I think probably it's a beneficial reduction in the likely degree of inflammation compared to waiting to catch the infection.
Okay, thank you. This is, I think, a question that we may have sort of already driven towards the answer already as well, but I do want to make sure that I've asked them all because I promised I'd ask them. If the completion of both studies is not due till early 2023, how can you be certain that there's no adverse medical problems to people down the track, years down the track? And I think, this is alluding to there's a common thread of concern, I think, because of the speed of the development and maybe people not understanding that the vaccine is not actually changing the DNA of the cells. But is there any other comments that you would make with that question?
Yeah, but they have to do these huge long-term studies to kind of get normal licensing of these things. So that requires that long-term follow-up. But as I said, when we've seen things in the past, it's always showed its head pretty early, like within 6 weeks. And so we're pretty reassured, obviously not 100% reassured, but we're pretty reassured that if it was going to happen, we'd probably know about it by now. But it doesn't seem to be. So we're still pretty confident that there's unlikely to be anything showing up at this time that we didn't already know about.
Certainly it seems very convincing that the risk from any vaccine seems to be a lot less than the risk if you were to contract COVID.
Yeah.
Okay, thank you. Maybe we can go, actually there's one more question before I want to sort of talk about the 2 different vaccines that we've got available or that are happening in Australia at the moment. One patient actually said, and I hadn't heard this before, but one patient said that they had been told that if you had liver damage or type 1 diabetes, that one of the vaccines will not be suitable for you. Now, I am talking about the 2 vaccines, I realise, but I hadn't heard that before. Is that something that you're familiar with?
I've not heard of any recommendation like that at the moment, because none of the vaccines are live. Like we have the live vaccines, that, which we don't really talk about viruses being alive, but the viruses that are kind of still able to replicate in a vaccine. So things like the measles, mumps, rubella vaccines, and then oral polio and chickenpox and shingles vaccines and yellow fever and so forth. So those ones when the vaccine virus is still able to replicate, or so-called live, those are the ones we wouldn't want to give people with weakened immune systems, and so particularly people on chemotherapy type things. But none of the vaccines that we've got being worked on, certainly for Australia and even for most of the developed world, none of those ones are considered to be live vaccines. So there's somewhere we've put the genes for the spike protein inside another virus. So you've heard of the Oxford one being one of the adenovirus vectors, where you put the part of the coronavirus that you're trying to get immunity to, the spike protein, inside a different virus, so an adenovirus from a chimp. But that chimp virus has been made non-replicating. And so that is not considered a live vaccine. And there's very similar ones as well. So the Johnson & Johnson and the Russian Sputnik ones, they're very similar on the adenovirus vector vaccines, but none of those are live. So we don't have any concerns about any of these vaccines being given to people with weakened immune systems. What is maybe the concern, though, is any vaccine in someone with weakened immune system may not be quite as effective. So it's not that it's going to cause more problems, it might not offer you as much protection.
Okay, and I think it would be great to come back to that because I want to talk about vaccines in relation to the timing of vaccines in relation to some of the treatments that our patients are on. So I'm going to grill you on that a bit more in a minute. But maybe if we could stop now and just look at the two vaccines that are available or will be very shortly available in Australia. And if you could explain the difference between the two and whether we're likely to get any other vaccines.
So the first one that was available, I think it was last week, was the Pfizer one, which is one of the mRNA ones, which appears to be probably the most effective one going around, but that might be partly just that they've done a really good marketing campaign and they did good studies early on. And I think the success rate is looking fantastic and much better than we could have hoped for. But that's one that's kind of being marketed as the best one so far. But I think there's nothing head to head comparing one vaccine with another one. It's just different studies where they had different outcomes. And in the Pfizer study, it looked like about 94, 95%. And in the AstraZeneca one or the Oxford one, same thing, AstraZeneca Oxford, the figures for that were lower, but they had different outcomes. And so I don't think we can directly compare the two percentages that were being thrown around. But the Pfizer one is the mRNA. It needs that cold chain thing where it has to be stored at -80, which is going to be a challenge for places outside the major cities where finding those super cold fridges is not that easy. They're very expensive fridges. So that will be used at this stage mostly for people working in hotel quarantine and hopefully now their families as well. And then the people working in frontline roles like the screening clinics and emergency departments and so forth. But then that one, once we've ordered quite a few doses, it's going to come to us quite slowly. So there's not going to be a huge amount of Pfizer vaccine going around. So then the other one being the Oxford/AstraZeneca one, which is that one that's the adenovirus vector from the chimp virus, that is going to be in much greater numbers. It's just arrived in the last few days. And that one is sort of, hasn't done as well in terms of the marketing because the initial study, they were a bit, they made a few errors in their study in terms of how they designed it and the different types of groups. And then they mucked up some of the dosing in one area, particularly in Brazil, where some people got half a dose the first time around and then a full dose second time around. And so because of those errors they made in their study, there's different figures. So the people who got half dose, full dose looked like they did better, but then people who got first dose separated by a longer time, up to maybe 3 months, also looked like they did better than people getting it separated by a shorter time of 3 or 4 weeks. And so because it was a bit more sort of mixture of how it was being given and some of the dosing, the study isn't as good. So they're repeating the study now and hopefully we'll get much more accurate figures. But the real life data coming out of, say, Scotland is showing that once you've had your first dose, the chance of being hospitalised with COVID is dropping by 95% within a couple of weeks. And so it is looking like it's probably better than their initial study. So I think they did some stuff ups with their study. And I think they'll get that right in the next few months with a better study. Right. But I think the real world data is looking mostly okay. The one problem being, though, with some of the new variants, particularly the one from South Africa, where it looks like the AstraZeneca one may not offer as good protection from catching the virus. It still offers pretty good protection against getting sick with it, but just doesn't seem to stop you catching it as well. And the Pfizer one maybe has a little bit better effect, but I think we have to expect that there will be more variants, that they will change even more, so that with any vaccine, whatever you get now, it's not going to be one course and you're done. You're going to need boosters in a year or something because of the new variants and probably because the immunity you get from these may not be all that long lasting like the flu vaccine. So I suspect we'll probably go down the path of you get something updated each year and hopefully they'll be able to make new vaccines for those new variants quickly. And with those new mRNA vaccines, one of the amazing things about that is if we decide, all right, the real problem is the Brazil variant or the South African variant, then they can change the code of that mRNA and have a new vaccine done within 6 weeks. They just have to kind of change the computer code of what they want for their mRNA sequence. And so it's amazing technology. And I think if we can harness that for some of the vaccines which we have that aren't that good, like flu vaccine, then maybe we can develop a whole lot better vaccines for them down the track too, once we've got kind of more time and energy to put into the flu again.
So am I catching a glimpse of a silver lining with COVID?
Yeah, it really is looking like amazing technology. And so I think there's a lot to be hopeful with that we will have better vaccines coming down the track because of this.
That's really exciting to hear. And I did hear that they were already doing studies into developing the new vaccines for the new variants that are coming through. So
so I think with the two coming to Australia, most of us will be likely to be offered the AstraZeneca one first, and that includes me. I'm not considered frontline enough to justify a Pfizer dose because I'm not working in the screening clinic, and so
infectious diseases clinician not getting an early vaccine.
No, some of my colleagues are down in the screening clinic each day, and so they're getting that one now. But yeah, I haven't been working in that clinic, so I don't qualify, and so I'll get AstraZeneca, and then assume that in 6 or 12 months be getting something else on top of that as a booster. But I think it's very safe to assume that whatever you get, you'll be needing something additional in a year or so.
Yeah.
So I'm certainly not concerned about getting AstraZeneca first. It does look very effective in preventing severe illness, and at worst you might end up with catching COVID but getting it as a mild cold, but you're not going to get the severe form where you end up in hospital or worse.
Fantastic. Well, thank you. Are you still recommended to have the vaccine if you've had COVID?
Yes, overseas they have been doing that because they've seen a lot of people who've had COVID now are finding that they're getting it again. And the worst example of that is in Brazil, in the central Brazilian area of the Amazonas state in the city of Manaus, where they had a huge amount of COVID going around uncontrolled in, say, last March to May. And it got to the point where a huge number of people in that area had died, and a huge number of the population in that part had become infected. And by about November, there was no infections happening at all. And they did a blood test survey to see who had antibodies. And they estimated about 76% of the local area had COVID already. And as a result, they're saying, oh, well, the reason we're not seeing any infections now is because we've got herd immunity. And they were sort of cheering that on and thinking, well, we're done. We've fixed the problem. But now it's actually happening again, and it's even worse this time. There's more people in hospital and there's more people dying, and a lot of those people had it last time. And so the question is that because it's the new variant and you're not protected from this new Brazilian variant from your previous infection with the old one? Or is it that your immunity just doesn't last that long anyway? Maybe when you get COVID, you have 3, 6, 12 months of protection and then you're not immune again. Or potentially that study where they estimated 76% had been infected was completely flawed, and maybe it was a lot lower than that. But I suspect it's probably more to do with the variants, and that the variants will mean you have temporary protection. There'll be new variants emerging in the places where they have uncontrolled infection. So the places that are studying it, like the UK, they're finding the variants because they're doing a lot of sequencing of the viruses. But then other places, like America, is not doing that much sequencing, and so almost certainly there's a whole lot of American variants we don't know about yet, that maybe also mean that the current vaccines are not going to protect you all that well for some of those. So it's still many things to learn. I'll just have to move again to get the lights turned back on. Sorry. Okay. All right. Sorry.
Fantastic. Thank you. At least it's keeping the blood circulating in your legs to get up and move every few minutes. I wonder now if we could talk about the timing of the vaccine, and I have a vested interest in asking this because I just haven't been able to find the answer out myself. So the government information about the phases of the vaccine rollout seem to indicate that people with cancer and other pre-existing conditions would be likely to be in phase 1B. I had some questions about that because a lot of people with neuroendocrine cancer, they've been living with their cancer for a very long time, so far more than 12 months. And I wondered about, but would still be considered to be, I imagine, quite vulnerable. So I wondered how strict they're going to be on that 12-month past diagnosis cutoff. Will it be up to an individual doctor to make a recommendation? Do you know how that's going to work?
The full details are not quite clear on that yet, unfortunately, but I think it will be a little bit based on the accuracy of your records. And they're saying that the best way is to approach that, to have that information in the system effectively. If you do My Health Record, if your My Health Record, usually done by your local doctor, if that's up to date and says that you're being treated for a cancer, then that kind of flags you as somebody who'll be in 1B and you will get notified. Other ways that can do it, there's a system of applying for it through the government website. And if you have some sort of documentation showing that you do have a cancer, and I think that would be any type of, when they say active within the last 12 months, any type of treatment. And if you're still being just followed up and it's 10 years later, then maybe they'll be hard to push. But if you've had any type of treatment at all in the last 12 months, then that would be considered acceptable. Right. And so if you've got some sort of letter documenting that, then you can put that in with your application.
So when they say 12 months, it's any active cancer within the last 12 months.
Yeah.
Right. Okay, because a lot of most of the patients in our group who are watching today will have, I think my earliest diagnosed patient was 1984, but most of the patients in this group have current tumours that are still being managed. So that's
so if you've got that, then I think that would qualify you as 1B.
Okay, that's super helpful. Thank you. I wondered about what will be the recommendation for patients, or quite a lot of our patients have had a splenectomy. Is there any particular guidance in that situation?
So again, that's certainly an indication for getting vaccinated because of your higher risk. And that would again qualify you as a group 1B for vaccination. But there doesn't appear to be any concern about the safety of the vaccines in that group. But there's always that concern with people post-splenectomy that maybe they won't respond quite as well to vaccines. And
what about patients who are going to have treatment? So we're talking, chemotherapy, radiotherapy, PRRT, which is the peptide receptor radionuclide therapy. Someone actually just has put in the comments there saying endovirus laser. I have to say that's a little bit embarrassing that I'm not sure what endovirus surgery is, but what's the guidance around timing of the vaccine if you've got things like that coming up?
So any type of thing like that where you're going to be getting some sort of vaccine or getting your cancer treated and you're deciding which to do first, it's really a way up of how urgent is the cancer therapy, for example, and is there any reason for saying, well, the vaccine won't work or is more dangerous, which it's much more the won't work rather than the more dangerous thing. So if you've got a very slow growing cancer where the treatment is not particularly urgent and you've got the option of vaccinating now, then you might say, well, let's vaccinate now, wait a couple of weeks and then start the cancer therapy. But if it's a situation where actually we need the treatment for the cancer right now, then you'd do that. Whether you'd say, all right, well, let's hold off on the vaccine till afterwards, or whether you'd give it anyway, but no, it's not going to be that effective. It's kind of up to the treating team. So you might give it, say, well, it may not work that well because you're getting chemotherapy around the same time. And then maybe once you've finished all your chemo, then we'll revaccinate you and hope that it has a better protective effect at that time.
So if the chemo is dampening down your immune system, are we talking like a couple of weeks before the vaccine's done its work? Or
yeah, so probably about, if you get the first vaccine, within 2 weeks, there is certainly some benefit. If you're getting the 2 doses, then we know that by 2 weeks after the second dose, then you're about as well protected as you're going to be. And so, but that for the Pfizer one, that would take 6 weeks. For the AstraZeneca one, if you're separating by a bit more, then that's going to take a bit longer. So probably most of the time, you're not going to have that luxury of waiting for a couple of months or anything.
And someone actually asked a little bit earlier, would it be an advantage to have the single dose vaccine over a double dose? I'm assuming you're going to say have the full.
We're not going to get access to that single dose vaccine, the Johnson & Johnson one, for quite a while. I don't think the government's done a deal with Johnson & Johnson at this stage. It may well come, but I don't think we've got any of that coming as far as I'm aware.
Okay. So the recommendation is to, with the 2 vaccines that will be available in Australia, they're both double dose. And my reading of the situation is for people with cancer, the biggest risk is it not working as well as it might be for someone with an intact immune system. So definitely to have the full course would be the advice.
If possible, but it might be that you want to repeat it down the track, just if you don't want to delay your cancer treatment.
Right. Yeah. Okay. Thank you. I wondered about You've answered a whole heap of my questions all in one answer, so I'm just looking through. I think it might be good for us to talk about sort of more immediate vaccine safety, because we have lots of patients with functional tumours, so they've got secretory syndromes, and some worry about people who have a tendency towards carcinoid crisis in other situations. Will there be any guidance for people where they've had dental work or other vaccines where they've, had a really significant carcinoid syndrome episode or carcinoid crisis? What's the advice there?
Yes, we know with people who've had a lot of issues with anaphylaxis that there are some concerns with the Pfizer and Moderna vaccines where there's about a 1 in 100,000 risk of getting an anaphylaxis type reaction after the vaccine. And usually that's within the first 15 minutes. So everyone's being kept for that time just in case, and they have adrenaline on hand if they need it. Specifically for carcinoid, I'm not aware of any extra precautions apart from that waiting for at least 15 minutes afterwards to see if there's any concerns with low blood pressure or anything like that. But the people that have had this anaphylaxis after the vaccines, they've all been treated pretty easily, and there's no kind of life-threatening concern about people dying from this. It's just, it happens. It's not ideal, but we want to treat it. And people who've got a strong history of anaphylaxis, we would certainly, discuss with them a bit more about, all right, do you want to choose a different vaccine, like maybe the AstraZeneca one rather than the Pfizer one, even though the Pfizer one maybe is a bit more effective.
And I think probably, the disclaimer I didn't give at the start, which I should have given, which was, very much, of course, talk to your own doctor about your own situation, because this is just general. So my apologies for not giving that disclaimer earlier in the conversation. But I think particularly for people, if you've got really unstable carcinoid syndrome or you've had carcinoid crisis with, relatively minor things in the past, then you're definitely going to want to be talking with your doctor about your individual risk. I did read something in my various sleuthing about if you've got short-acting octreotide that you carry because of that risk of carcinoid crisis, then it's worthwhile taking that with you to your vaccine. And I would probably add that you'd want to have that vaccine done in a major hospital. It's probably not rocking down to your local pharmacy for you. I think you'd want to have all of the bells and whistles available if that was required. Someone else asked about people with carcinoid syndrome are generally advised to avoid adrenaline injections because that can stimulate a carcinoid crisis. And so what to do if they have an allergic reaction, but it sounds like the risk of allergic reaction is much smaller than in lots of other vaccines. Am I correct there?
Yeah, it certainly it's there, but it doesn't appear to be a huge problem. So there's definitely been seen around the world, but it doesn't. No one's been sort of super concerned about, oh gosh, this is going to mean no one's going to take this vaccine, that we need to stop using it or whatever. And whereas with some vaccines in the past where they have caused problems, it's been very quick that people have said, look, let's abandon this vaccine. It's causing more side effects than it's worth. I don't know. I think it would be kind of risk-benefit analysis at the time. And most
obviously,
of the time,
if your throat's closing, they'll give you adrenaline and then manage the carcinoid syndrome.
I think that would be the case.
Yeah. So have your vaccine somewhere where there's bells and whistles and people in scrubs and somewhere down the hall to cart you off if you need it, but it's very unlikely to happen. I wondered about people with adrenaline-producing tumours. So both in terms of the priority of where they might sit in the 1A, 1B, the phasing of the rollout. So I'm talking pheochromocytomas and paragangliomas that often people are told that's not really a cancer, but it's still very much in the realm of neuroendocrine tumours. So would they be treated with the same priority as people with gastrointestinal neuroendocrine tumours, for example, but also about the safety of that vaccination process when they have an adrenaline producing tumour? Is there any comment there?
Yeah, I don't know whether there's been any signal of extra concern with that group. I think any type of tumour or cancer at all will make you 1B, even if it's something that's relatively benign like that. I think you'd still meet the criteria as well. That's a cancer, and so you still warrant getting earlier vaccination than somebody who's the same age and otherwise doesn't have that type of condition. So I think it'd still be 1B, but I'm not aware specifically if there's any extra problems. I don't imagine so, but just not sure if that that's
and
been
that
studied.
might be something that we can ask our UK cousins about, because I've given you a little bit of a spoiler, but there is a plug for our next week Facebook Friday conversation, because we're hoping that we might be able to have some of our UK neuroendocrine cancer counterparts along to share some of their experiences. So I'm imagining that they might be able to share some experience regarding that as well. So, but thank you. I wondered, just looking through the questions, I think there's a question about monthly hormonal injections so this is somatostatin analog injections that's for active tumours. So I think that would put you in category 1B. Would you agree with me there?
Yep, Patrick? I would agree, yes.
Yeah, great. Okay. I'm just having another look at some of the other questions that are coming through and making sure I've covered them. And if you've got questions that you want me to put, I'm getting towards the we've been very efficient with our time. Normally we yabber on a little bit more. So I'm very impressed because you're quite concise, Patrick. But just let me know if there's other questions that come through. But while maybe we just give people a last minute chance to type any other questions into the space. We've had a couple of issues in Australia with the vaccine rollout. We had one provider up in Queensland who hadn't quite done the training program and gave too much vaccine to a couple of people, and we had some situation in Werribee where some vaccine wasn't, they couldn't ensure that it had been kept at the correct temperature, so that needed to be discarded. How's things going at the Austin with the, I know it's a huge thing to be vaccinating all these people.
Yeah, well, we fortunately haven't had any issues like those you described so far. There's always been that concern that any time you make a multi-dose vial for anything like that, whether it's anesthetic drugs or adrenaline or vaccines, that when you've got multiple people having to put needles in there, that there's a concern that maybe someone will muck it up and contaminate the dose early on, and then subsequent people could get exposed with it. But no, they're being really careful. The problem was they wanted to get as many people vaccinated as possible, obviously, and there's not that many of those little glass vials around. So if they did single dose vials, then we wouldn't have anywhere near as many doses to go around the world as we do. So they sort of made that, well, okay, if we want to get more doses, we'll do that. In terms of the excess dose being given in Queensland, that almost certainly is not a problem. When they did the studies of what is the right dose to give, they essentially look for what's the minimum dose we can give to get effectiveness. And maybe getting a bit extra might even be potentially a bit more effective, but because we want to get as many people done, we'll just try and find what's the minimum dose that works. And so getting an extra dose or 4 times the dose, whatever, it's almost certainly not an issue. And I don't believe there's been any problem in those patients, apart from one got told, well, the surgery you're going to have, we might just delay it just to make sure. But otherwise, no actual health problems. But we've obviously tried our best to be very careful with training the staff as well as we possibly can. And most of the public hospitals that are doing this, I think, have had no problems so far because of the staff being so well trained. And I think the problem has been that kind of private situation where profit often comes first and training people may not be as much of a priority. And so I think the public hospital system has done a really good job so far with no issues like that. And hopefully the rest of the people kind of learn from the mistakes quickly and don't make them again.
And I think, I guess if there's a silver lining to take from that episode is that it happened really early and that it was picked up so quickly. And I think it's probably going to make everybody extra careful. If they weren't being careful already, then they're going to be very much more careful now. So, so I think that's a real positive. So you haven't had the vaccine.
Not yet.
When are you likely to have it?
I'm guessing sometime in the next 1, maybe 2 months. But yeah, I'm not sure yet.
And I imagine that you're telling family and friends that you're going to be, that they should as well.
Yeah, so certainly. I think if we can get as many people as possible vaccinated, then that gives us a much greater chance than anything else of going back to something vaguely resembling normal again.
And I think we're all looking forward to being able to do that with more confidence, and and also seeing our the impact of this overseas, and the way that it's, I know that our cousins in the UK have endured a very long, cold, locked down winter, and so observing that from afar, I think, is a really important reminder of we don't want to go there.
Just a sobering thing of hearing from some of the hospitals in London that the average junior doctor working in the general medical team in the recent months where things got really bad there, they were doing between 6 and 10 death certificates per doctor per shift. Whereas my general medical team in a normal time, they might do one every 3 or 4 weeks.
Wow,
and so it's obviously it's hugely affected the population. The numbers of healthcare workers are showing signs of post-traumatic stress disorder over there is huge. And I think they're going to have a lot more problems down the track just from the damage psychologically done to the nurses and the doctors working in that kind of scenario.
Yeah, it's very sobering. Yeah. I did have another question that's just come through the feed, which it's good to have a chance to ask you. So you actually mentioned the family members of hotel quarantine people. So is that a new that's a change that's come about? It's just
changed in New South Wales. I'm hoping that the other states will do that as well, because if we can do that, that gives us a much better ability to avoid further problems leading to lockdowns and so forth. So obviously those people in hotel quarantine are at the highest risk. They're not as well trained as medical nursing staff at using PPE, and they're in a situation in a hotel rather than a hospital that's not very well designed for preventing transmission of infection. And so their risk is much, much higher. And we saw within the hospitals in Melbourne, all the hospitals that had lots of patients had lots of staff catch it. So if we can't stop a well-trained medical and nursing staff from catching this in hospital, there's no way we can stop hotel quarantine workers from catching this there. And if we can stop them catching it, or maybe they catch it but asymptomatically after a vaccine, if we then stop their families from catching it, then we can protect the rest of the community as well.
So the question was, and that's fantastic to hear, because I've heard lots of people talking about that over the past few weeks. So it's great to hear that sort of maybe there's some change there. The question was from a patient who's, will be presumably offered the 1B phase. Will family members of patients be offered in the same phase, or will they be relegated to their spot in the queue down the track?
Yeah, I think it's the latter. As far as I'm heard, I think it is still the latter. But because there's not that same risk of catching it, I think there will be that the other family members will have to kind of wait for their turn.
So there's one more question, and I think that's probably all we're going to have time for, because I know you've got to run to your next thing, and you must be uncomfortable. So thank you for bearing with us. One person just said, look, I don't have an e-health record. How would I register for my vaccine? How are we all going to find? And I'm asking the same question because I'm like,
on the government website, there's a thing of where am I in the queue sort of thing, and you can sort of put in your details with that. If you have some sort of documentation, especially if you can have a PDF file of something about your medical condition that you can upload, then it will recognise, yes, you are being actively treated for a cancer, so therefore you are officially 1B.
And I guess we're all sort of waiting for more information about where the 1B people will be vaccinated. I'm hearing comments about GP clinics being likely. Have you got any more information about that?
So what we're doing here at the Austin, initially with this first round, where we're doing the hotel quarantine workers and the screening clinic stuff, we're doing that in a relatively small clinic at the Austin Hospital. But then once we get access next week to the AstraZeneca Oxford vaccine, then we're going to have a much bigger clinic, which will be open to all the people, not just staff members, but the local population who are in that 1B group, that they'll all be able to come to that, and we'll have a sort of huge production line of vaccinations happening there. But there will be sort of websites through the government saying, where can I get vaccinated in my area?
Okay, so I think I can say to our patient community who are watching, as soon as I know more about how, you know, what, like, for example, what documentation you might need to rock up to somewhere like the Austin or wherever it is near you, as soon as I've got information about that, you'll be the first to hear that.
Yeah. So if you can get hold of any recent letter saying that, yes, you have this condition that qualifies you, then that's going to be adequate.
Yeah. Perfect. Look, thank you so much, Patrick. You've been marvellous in answering our questions so clearly and concisely, and yet with so much detail. So we so appreciate your time, and especially sitting on the floor in your waiting room. So that's above and beyond. We're going to watch this video again tomorrow as a watch party, and I'll be able to chat online with anyone who's watching on the day to help clear up any last minute questions, or to make notes for phoning a friend later on if I need to do some homework with more questions. And the plug is, yes, that next week we're likely, hopefully, fingers crossed, that we're going to have so hopefully a patient and also a representative from Neuroendocrine Cancer UK who will be able to share some of their experiences, given that they've had such a large proportion of their population already vaccinated and are living with the impact of a very big outbreak of COVID in their community. So they'll be able to provide some reflections on how that's impacted on them in the neuroendocrine cancer field. So thanks in advance to those people for next week. And thank you to Patrick. It's been fabulous talking with you, and I've learned a lot, and I know our community will have learned a lot too. So we're really very much appreciated. And thanks everyone for joining us live today. And you know where to find me. I'll make sure my contact details are in the notes. So if you've got more questions along the way, then just let me know and we'll find an answer to them. Thanks, everybody.
Thanks, Kate.